good morning. So I have the honor to present Dr. Edward Wolin, who is our current director of the Center of Carcinoid and Neuroendocrine Tumors. He is also professor of medicine in the Department of the Division of Hematology, Medical Oncology. He was previously the director of the Neuroendocrine Tumor Program at Montague, and before that worked for 2 decades at Sinai, establishing the largest carcinoid neuroendocrine tumor on that side, on that coast, not on this coast. So we're excited to have Dr. Wolin for the grand rounds today. He's going to talk to us about the current management of neuroendocrine tumors.
Thank you. Well, it's a great honor and privilege to be standing here to talk about neuroendocrine tumors on a podium that previously Dick Warner was speaking from for so many years, and I think we all owe a tremendous debt of gratitude to the program that he established here years ago in the Gastroenterology division, and what he's done for the field in the decades that he's worked, and I just want to acknowledge that. My disclosures. We have a wonderful multidisciplinary neuroendocrine program here at Mount Sinai. Michelle Kim, of course, being an integral part of that, along with myself. We have a weekly neuroendocrine tumor board, which I established a few months ago, which is really very robust. And we have multiple specialists, as you can see, from all different areas, sitting at the table, talking to each other and working out management, specifically of neuroendocrine tumors. We have made the separate from the GI tumor board because there's so many cases now of neuroendocrine cancer. We have roughly 10 cases every single week that we're discussing in a multidisciplinary fashion. It's a wonderful tumor board if anybody is able to attend, attendings, residents, fellows, or anybody. It's a wonderful learning experience. And just let you know that. Okay, first of all, the gastroenterologists have a very critical role in diagnosis as well as management of neuroendocrine cancers. This is from a paper that I presented at the DDW, an analysis of 758 American patients to see what was going on with making the diagnosis of neuroendocrine cancer. 53% of these patients required more than 2 years to make a diagnosis of a neuroendocrine tumor. 34% more than 5 years. Many of these people with florid carcinoid syndrome or multiple admissions to the emergency room with small bowel obstruction who had never had surgery before and had no reason to have SBO but never were evaluated or evaluated properly. The number of office visits was staggering. The average number of healthcare providers, physician visits, was approximately 6 different healthcare providers with approximately 13 office visits or hospital visits before the diagnosis was even thought of. Once the diagnosis was thought of, it was usually a very simple matter to make the diagnosis. But just thinking of it is the challenge. So I just want to remind everybody that this is something that we should think about. And almost all of the misdiagnoses were gastrointestinal. And you can see irritable bowel, gastritis, Crohn's disease, ulcerative colitis, ulcers, all kinds of things were blamed for the patient's symptoms. And a lot of people were sent to psychiatrists for being crackpots or being told their severe carcinoid flushing and diarrhea was due to being a nervous wreck and having menopausal hot flashes and just blown off without even an evaluation. So there's just all kinds of things that have happened, and I just want to alert you to this. The other thing I wanted to share with you is that a lot of times, actually about 25% of ileal carcinoids, which is the most common place where they start, are multifocal, 25%. And that's actually a lot. And some of these are very small, and it's actually possible to have metastatic disease even from small tumors. This can very easily be missed. This particular patient was missed on CAT scans and MRIs, and even a wireless capsule, amazingly, didn't see it. But it did show up on a double balloon push enteroscopy. When I was at Cedars, along with the group with Neil Mann and Simon Lowe and all the people doing interventional procedures in GI, we had 189 patients who had an unknown primary of a neuroendocrine cancer. Almost all of these presented with liver metastases of a neuroendocrine tumor, unknown primary. And they had already had all the usual tests. Of these, 13 underwent a double balloon push enteroscopy, And 12 out of the 13, 92%, the primary lesion was identified. It's been better than any other test so far. It was not compared head-to-head against the gallium-68 dotatate PET because at the time the study was done, we didn't have that. That's also a wonderful test, but you can find things here that are even tinier. We had a patient with diffuse liver metastases and a 1 millimeter primary in the ileum, biopsy proven at DBE. That's remarkable. And we've had several patients with tumors less than half a centimeter and metastatic. So this is very different than a primary tumor that arises in the appendix or a primary tumor that arises in the lung, where teeny little tumors like that just don't metastasize, you don't see it. But in iliocarcinoids, they're very sneaky, they're submucosal, they get into the blood vessels more easily, and they can even present with distant metastases with tiny tumors. So just be aware. I want to just talk for a moment about a few concepts in evaluating neuroendocrine tumors and evaluating treatments, just so we're all talking the same language. Neuroendocrine tumors are basically divided according to what their cells of origin would be if you were an embryo. It's a kind of peculiar way to think about diseases, but this has become the tradition with neuroendocrine cancer. So they're divided into foregut, midgut, and hindgut, which of course don't exist in adult people. The foregut tumors include thymus, lung, esophagus, stomach, pancreas, although pancreas has enough special features that we put it separately. The midgut tumors are most commonly terminal ileum, but they can arise anywhere in the small bowel, the cecum, the proximal colon, the appendix. The hindgut tumors, distal colon and rectum. Each of these areas have different responses to treatment. They have different biology. They have different genetics. They have different molecular biology and genomics. So I think it's important to just realize that these are not all exactly the same. The grading of the tumors has been for the last 8 years, been according to the system of the 2010 WHO. Tumors were divided into well-differentiated and poorly differentiated neuroendocrine tumors, two basic groups. The well-differentiated tumors had a Ki-67 proliferative rate of not more than 20%, and poorly differentiated tumors had more than that. There are also criteria, as you can see, for mitotic count, whether it's 1 or 2, whether it's 3 to 20, or whether it's more than 20. And this applies to all sites of disease except for lung, which has its own peculiar characteristics for grading the tumor based on mitotic count and necrosis of Ki-67, the pathologists couldn't agree upon. So in any case, this now, in 2018, this applies to the entire gastrointestinal tract, but does not apply to pancreas. Because last year, the WHO realized what we've known all along, that somebody with a Ki-67 of 23% that looks perfectly well differentiated is not the same kind of cancer as an extrapulmonary small cell cancer of the pancreas with a Ki-67 of 95% that's growing like a bat out of hell. That's a different kind of a cancer. And it turns out they really are very different and have different biology. So after a meeting of all the major pathologists in the world doing this kind of grading, this is the official new system now for pancreatic neuroendocrine tumor. I'm pointing this out because anybody that you see in your practice who has a pathology report from 2-3 years ago isn't going to be having this system. And you have to realize that there's been a major change in a different way of thinking about treatment, as we'll be talking about. The difference then is the splitting of well-differentiated and splitting the poorly differentiated group into two things. One is the well-differentiated grade 3 neuroendocrine tumor, that's the yellow. The second is the poorly differentiated neuroendocrine carcinoma, is the terminology we use, neuroendocrine carcinoma grade 3. And they both have mitoses greater than 20%, although the well-differentiated group has basically a mitotic count that's always less than 55%. And the poorly differentiated group is almost always more than 50%. And most importantly, they have different genomics, which are very clear and can separate these groups if there's any question about it. The neuroendocrine tumor grade 3, the more well-differentiated kind, the Ki-67 is usually between 21 and 36. It does not have p53 mutations. It doesn't have retinoblastoma gene loss. And commonly, there are ATRX and DAX mutations. DAX should have two X's. Those are chromosome remodeling genes, are often mutated. The neuroendocrine carcinoma grade 3, the Ki-67, as I said, is in a higher range. It says 21 to 90, but it's basically 50 to 90. They very commonly have p53 mutations, very commonly have RB gene loss, very rarely have somatostatin receptor expression on scan, somatostatin receptor imaging. Very common, of course, in the typical carcinoid tumors that are trioscans and gallium 68 dotatate PETs are positive, but these scans are usually negative in the neuroendocrine carcinoma grade 3, and the chromosome remodeling gene mutations are common in the neuroendocrine tumor and rare in the neuroendocrine carcinoma. There are lots of other differences, but these are the ones that are figuring into the staging. So just realize that this applies right now to pancreatic neuroendocrine carcinomas, and hopefully the pathologists are going to get their act together soon and apply this to all gastroenteropancreatic neuroendocrine tumors, because the differences are real in all the other sites as well. Okay, so the genomic analyses, I talked about. The important take-home message from this is that mutations are actually quite uncommon in well-differentiated tumors. We don't have a big mutational load, and if you do genomic analysis, you don't very commonly find actionable mutations with the same frequency that you find in other kinds of gastrointestinal cancers. But some people can have mutations, and occasionally they can be of importance.
Sorry. So there are germline mutations of YH2 and PRCO2 with these tumors, or somatic mutations?
These are somatic mutations. In terms of genetic mutations, the pancreatic neuroendocrine tumors are associated with a bunch of different germline mutations, including MEN1 and neurofibromatosis. And there are a bunch of things that can cause a germline mutation for pancreatic neuroendocrine tumors. Carcinoid tumors that are familial with the germline mutation are uncommon. There's a fellow at the NIH, Stephen Wank, who's spending his career working on the genetics of familial carcinoid. But he's limited to the fact that there are probably 40 kindreds in the whole United States with familial carcinoid. It's not normally a disease that runs in the family.
But if we have patients who are YH mutated, we're not necessarily looking for pancreatic neuroendocrine.
No, not at all. And the next concept after site of origin and grade is the functionality of the tumor. Does it make hormones or doesn't? The ones that make hormones enough to cause a clinical syndrome, this is very important, enough to cause a clinical syndrome are called functional, and the rest are called non-functional. You don't define it by an abnormality in a laboratory test, because if you look hard enough, you'll find that almost everybody with a neuroendocrine tumor will have a slight elevation of VIP or gastrin or this or that. That doesn't make it a gastrinoma or a VIPoma. Those are patients who have a clinical syndrome, and typically the levels of hormone is quite high. So you need both the elevated hormone and the clinical syndrome. Carcinoid syndrome is the most common. Depending on how you define carcinoid syndrome, which is kind of a mess in the literature, people are reporting between 8 and 35%. Some people will claim all the way up to 50%. One of the problems is that if everybody who walks in the door with diarrhea is called carcinoid syndrome, you have a problem, because people have had right hemicolectomies typically. They have bile acid diarrhea, they have bacterial overgrowth diarrhea, they have all kinds of competing causes of diarrhea. People have short guts sometimes. And if you have 4 bowel movements a day, which is the usual cutoff for calling something diarrhea in a carcinoid syndrome, you can get all mixed up. So when patients are being evaluated at academic centers, and there's a serious evaluation of what's causing the diarrhea, a department like this doesn't call everybody who walks in the door carcinoid syndrome. It's different than out in the community where people are reporting. Everybody who has a diagnosis of an appendix carcinoid taken out 10 years ago now is carcinoid syndrome if they are having bowel movements too much. Okay, functional pancreatic neuroendocrine tumors are famous, although they're obviously less common in the world, but we see lots and lots and lots of them. Gastrinomas are pretty common, arising in the pylorus interim of the stomach, as well as duodenum and other sites, insulinoma, glucagonoma, somatostatinoma, and you can call it any kind of thing you like. And oma just depends on the hormone it makes. We have PTHRP-omas that make PTHRP and hypercalcemia, for example. We have grelinomas, but these are the more common sort of syndromes. Okay, I'm just going to talk a moment about some of the symptoms of carcinoid, and then we can talk about treatment. Okay, first of all, diarrhea is a secretory diarrhea when it's part of carcinoid syndrome. It's almost always mediated by serotonin, which is quite high, and we'll talk more about it later. You typically have a high stool volume. Diarrhea persists when fasting, which is one of the characteristics of secretory diarrhea, and there's no osmotic gap with osmolality. Again, not everybody who walks in the door with carcinoid diagnosis and diarrhea has carcinoid syndrome diarrhea. You can also get flushing, and the cause of flushing is not so clear because it's mediated by other things other than serotonin. Carcinoid tumors make all kinds of biologically active things. They make all kinds of kinins, bradykinin, tachykinins. They make vasoactive peptides of all sorts. And you can get flushing just by dilatation of the blood vessels. That's what flushing is. And since the skin on the face and the neck is the thinnest in the whole body, the face and the neck are more prominent whenever you have vasodilatation. The underlying pathophysiology is vasodilatation. That's why even if you blush, your face and neck are more red, because that's when you see the blood vessels through the skin most easily. It's typically a dry flush, meaning you don't sweat at the same time. When carcinoid mediators stimulate flushing, it doesn't stimulate the sweat glands in the same way that neurologic causes like menopause and blushing and some other neurologic issues can cause flushing. But there are some people anyway who sweat, even though it's not classic to sweat. Carcinoid heart disease is sort of a dreaded complication of carcinoid syndrome. It seems very clearly to be related to high serotonin levels, typically greater than 1,000 picograms per milliliter, or urinary 5-HIA greater than 57. You get endomyocardial fibrosis. That's particularly a problem in the right-sided valves, the tricuspid and pulmonary valves. You can get left-sided involvement if you have a previously unappreciated patent foramen ovale and you have an intracardiac shunt. But otherwise, the serotonin gets metabolized in the lung on the way and you don't get left-sided involvement. If you have such a thing, you need to be very carefully evaluated. Fortunately, we have some very good people here, both in cardiology and cardiac surgery, to deal with it. But if you have really major symptoms from carcinoid heart disease and you don't treat it, the life expectancy is something in the neighborhood of 18 months. And if you have valve replacements, which are getting safer and less scary than they used to be, you can actually have a perfectly excellent response to treatment and live for years and years. So I think it's important to recognize this. I've had people who have seen, multiple doctors, including cardiologists, and have never been properly diagnosed. And then they come in the room to see me, and their jugular vein is going like this with every systole because of the blood shooting up backwards. And you can see across the room they have wide open tricuspid regurg. You just have to think of it again. Like other things, it's pretty easy to order an echocardiogram, which is usually the diagnostic test. But it's amazing what doesn't get done sometimes. Okay, in addition to causing fibrosis in the heart, you can get fibrosis anywhere. You can get intraperitoneal fibrosis. You can get retroperitoneal fibrosis. You can have all kinds of complications of these fibrosis, inclusions of various bowel structures and vessels. You can get penile fibrosis, Peyronie's disease. You can get fibrosis of anything because one of the things that serotonin does is stimulates fibrosis. If anybody's interested in doing a really interesting research project, when you have metastatic carcinoid, you can have intense fibrosis all through the abdominal cavity, intestines all stuck together. Surgeons freak when they see this. It's so hard to operate. Yet when they have 20 liver metastases, there's no fibrosis at all in the liver. So there's something about the microenvironment in the liver that prevents fibrosis that is happening right next door in the perihepatic nodules. So just think about it. But pathologists never see fibrosis in liver metastases. Okay, the only cases of pellagra I've ever seen in my life have been in people with carcinoid syndrome. And sometimes it isn't appreciated because pellagra not only causes diarrhea and red skin, which sometimes people mistake for carcinoid syndrome, but if you remember the four Ds from medical school, diarrhea, dermatitis, dementia, and death, I think is the way I learned it in medical school. The rash is a red rash. It's not like a carcinoid flush. It's kind of thick and a little bit scaly. The word Pellagra comes from the Italian meaning ugly skin. And that's because of this characteristic rash. You don't have to be demented. You could just have some psychiatric symptoms sometimes. But when somebody has really severe redness all over their body that sort of stays there, one of the things you think about is pellagra. It's very easy to measure serum tryptophan and find you don't have any. And it's very easy to treat by using high protein diet and niacin. But it's a serious condition if you miss it. And every year I think I see 2 cases or so. It's not a real common thing. But in America, to have it at all is shocking. I don't know how often people see this. It's rare. Okay, rosacea is chronic dilatation of blood vessels. It can happen from any cause of chronic flushing, that the blood vessels just stay dilated. You don't usually get this from carcinoid syndrome because the flushes usually only last for about 2 minutes and go away and the body adjusts to them. But if you have carcinoid tumors that make histamine, which particularly a lot of foregut tumors will make, you can get flushes that last for 30 minutes at a time or last most of the day, and you can't present with rosacea. So just be aware of that, because once you get rosacea, it isn't something that's easily reversed. It's cosmetically not very nice. So how do you treat the carcinoid tumors? We've discussed them in our multidisciplinary tumor board with all the different specialties represented and tried to make individual personalized decisions, because it's not a standard cookbook, but just a few basic principles that you surgically remove all tumors from abdomen, liver, intestines, whatever, if they are removable. If you can get out 90% of the tumor, there are several studies, non-randomized, showing that there is an association with longer and better life. It would need to be done by a very experienced surgeon, and you don't just carve on things because it's there. But it is a disease where cytoreduction makes a difference. Carcinoma of the ovary is another disease where cytoreduction makes a difference in survival. Cholecystectomy should always be done if a surgeon is in the operating room doing something in the abdomen and you have metastatic neuroendocrine tumor, take out the gallbladder. If you're not at a place like Mount Sinai, you need to specifically tell the surgeons to do it, because otherwise they will think of doing an extra cholecystectomy. It adds practically nothing in the way of operative morbidity if you're already taking tumors out from the abdomen. And it not only prevents gallstones from somatostatin analogues, which happen in about 50% of people on chronic octreotide or Lanreotide, but in addition, when you're doing hepatic artery embolization, which a lot of people need sooner or later, you don't have a risk of off-target embolization through the hepatic artery, since the cystic artery is often a branch of the hepatic artery. So you might as well take out the gallbladder while you're there and prevent complications.
What's the mechanism of gallstones in people on somatostatin? Is it just the
stasis impaired?
Just the stasis.
Just stasis.
Nothing to do with the bile composition.
Not that I know of.
Did anything to do with cholecystectomy?
Yes, human inhibit cholecystectomy, and it causes biliary stasis. Okay. Hepatic artery embolization is a wonderful treatment we've been doing for years. It often controls cancer for a year, year and a half. It can cause major death of a lot of tumors in the liver. Typically, half a liver is done at a time, like the left lobe and the right lobe. When people have too much disease, sometimes it's divided into more segments, and you do more than 2 treatments altogether. Just a few things to keep in the back of your mind is that in the era of peptide receptor radiotherapy with lutetium-177 dotatate, it's a bad idea to do radioembolization. There's one major paper that came out, University of Pennsylvania group, which followed multiple patients who had been treated in Europe and then came back to the United States before we had the approval of PRRT in the United States. And there was a very high incidence of hepatic failure, radiation-induced liver disease, in those individuals who had prior radioembolization. There are places like Memorial Sloan Kettering and University of Iowa that refuse ever to do PRRT treatment on anybody who's ever had a radioembolization. However, in studies that we've done here, most people get away with it, and you could do it, but patients have to understand there's a higher risk. So just because people have had it doesn't mean you can't have PRRT, but there is a higher risk, and radiation-induced liver disease can be pretty scary, and people have even died from it. So I think that going forward, it's a good idea not to do radioembolization, even though it's more user-friendly for patients. Gland embolization and chemoembolization being the options. We have a study which is about to open here that we're doing in conjunction with the University of Pennsylvania called GEP-NET, which is a randomized comparison of gland embolization versus chemoembolization to see if this non-randomized data, which I'm showing you here, is really valid, that with chemoembolization you have a longer period of tumor control. But we don't really know that, and I think it needs to be tested properly because there are plenty of centers that do one, do some do the other, and some sort of do it almost randomly depending on what people ask for. So this is going to be a study doing 2 standard of care treatments, but randomized between the 2 of them. Okay, now treatment of neuroendocrine tumors is actually something very exciting and something I'm very involved with. The situation is that when I started neuroendocrine tumor treatment as a specialty, there was absolutely nothing approved by the FDA for treating carcinoid tumors. And to this day, octreotide has never been approved. There's nothing approved for treating the disease. Only for treating diarrhea and flushing, we have octreotide, but we don't have anything approved for the disease. And in the 1980s, streptozotocin was approved, although it causes renal toxicity, which isn't always predictable, and GI toxicity. It's not used nearly as much today as it used to be. So just in the last few years, in the last decade, you can see all the new drugs that are approved based on these randomized prospective phase 3 trials giving level 1 evidence of effectiveness. So now all of a sudden we have a ton of things to do, and the challenge is figuring out what do we do when. And I'm fortunate enough to be a major part of most of these studies, and it's a very exciting time watching all of this happen. So I'm going to approach treatment by talking about molecular receptors on the cancer cells. That's pretty much how in 2019 we talk about treatment of other kinds of cancer. We think about what the molecular targets of the treatment are. The first molecular target to talk about is the somatostatin receptor. Somatostatin, as you know, is a naturally occurring peptide hormone. It has 14 amino acids. And like all peptide hormones, its action is mediated by binding to the G protein coupled somatostatin receptor. When you have an agonist like somatostatin or its analogues binding to the G protein coupled receptor, it binds tightly and then internalizes into the cell. This is very important because not only is it able to exert its action directly, but when we use it as a ligand for delivering therapy or diagnostic isotopes, it really traps it in the cell and you have very specific binding. In addition to stopping hormone secretion or slowing down hormone secretion, the somatostatin analogs also induce G1 cell cycle arrest, induce apoptosis in neuroendocrine tumors, and are effective as anti-neoplastic agents, as we'll talk about. 80 to 90% of neuroendocrine tumors express somatostatin receptors, and fortunately, almost all of them are so-called type 2 receptor. There are 5 recognized types of somatostatin receptor, maybe 2 subtypes of type 2, but just call them 1, 2, 3, 4, 5. And somatostatin analogs that we use, octreotide and lanreotide, bind specifically to somatostatin receptor type 2. This sometimes can be a limitation, but actually most of the effects of somatostatin on proliferation of neuroendocrine cells and hormone secretion are mediated by the binding to type 2, so we actually get away with it, even though it's not as good as the real thing. This is mean receptor binding affinity measured in IC50 nanomoles per liter, and the lower the number, obviously, the better the receptor binding. You can see that native somatostatin binds really well to everything. Octreotide primarily to receptor type 2. Same with lanreotide. We have one called pizeriotide, which I've been involved in developing, which binds to all but type 4. So that's a pan receptor drug and can work in some people where octreotide doesn't and has some other actions. The toxicity of neuroendocrine tumors, this is from a slide from Marianne Pavel, I want to share with you, are largely GI toxicities and largely preventable. If you look at the list on the top, you'll see diarrhea, steatorrhea, flatulence. Almost always, these top three toxicities are part of the same thing. They're due to decrease in pancreatic enzymes by the pancreas. And this is a common side effect of somatostatin analogs. Not only does it stop production of endocrine hormones, but it stops production of exocrine enzymes by the pancreas. It works so well that in Europe, this is a common treatment for pancreatitis. But in America, everybody knows it works, but it isn't officially approved for treating pancreatitis. But it does slow up the production of pancreatic juices. And this is what happens. So you end up with pancreatic steatorrhea. You have malabsorption. If you recognize it for what it is, it's so easy to treat by giving somebody a pancreolipase like Zenpep or Creon. You could prevent this from being such a problem. And the diarrhea, steatorrhea, and flatulence are usually part of the same syndrome. There are occasional people that really do get bad diarrhea from a somatostatin analog injection, but that's really rare. It can happen. Okay, injection site pain, part of it's due to technique, part of it's due to the octreotide LAR needle. It's a little bit like a horse needle. We talked about gallstones, and other side effects are remarkably rare. Blood sugar can go up, blood sugar can go down. You suppress insulin, you suppress glucagon, not completely, and you suppress them both in some kind of a balance with each other. It's amazing how well people can tolerate this stuff and be on it for years and years and years because you really are inhibiting lots and lots of hormones. Okay, this is a classic study that was published in 1999 demonstrating the effectiveness of octreotide LAR in controlling carcinoid syndrome. There was a period of washout to see what would happen without the drug. And then octreotide LAR, you can see a dramatic reduction in flushing, dramatic reduction in diarrhea, and drop in 5-HIAA production measured in the urine by 50%. And based on this, it was approved for treatment of diarrhea and flushing. And as I said before, it has not yet been FDA approved for treatment of carcinoid tumor. There was a study done in Germany known as PROMID, randomizing people between octreotide LAR 30 milligrams and placebo, but the study was stopped prematurely. It's a very difficult to interpret study since the control group, since the treated group actually, with octreotide LAR had progression-free survival, or time to progression as they called it in that study, of 14 months. And that's a shorter period of time than the control group in the study I'm about to show you with Lanreotide. So I don't know how to interpret that discrepancy between trials, except just remind everybody the cross-trial comparison and non-randomized things is fraught with systematic errors. But I really have not seen a major clinical difference between the two drugs. There are an awful lot of people who are on somatostatin as an octreotide as an anti-cancer drug and have been on it for years and years and years, and their cancer is still under control. And the same with Lanreotide. They've never been compared head-to-head. Okay, the Lanreotide study was a classic. This is the Clarinet trial. How to make clarinet out of this name is a real stretch, but if you look at the yellow letters, you'll figure out how to spell clarinet. And the randomization was between Lanreotide 120 milligrams, which biologically is quite similar to octreotide 30 milligrams, given once every 28 days, and placebo. Lanreotide is a really interesting drug. It's a somatostatin analog, very much like octreotide, except instead of having a vehicle to allow it to be sustained released, if you like, from an IM injection, it's done by taking pure Lanreotide and water. And just by putting it in high concentration and pressure, the Lanreotide will self-organize into a crystalline structure in the form of a nanotube. So all of the Lanreotide becomes crystallized up, and then there's a steady state that exists between the nanotube form and the free Lanreotide. So you inject the Lanreotide in water subcutaneously, a much more user-friendly treatment under people's rears. And then over the next 4 weeks, the Lanreotide gradually dissociates from the nanotubes, maintaining a steady state blood level, equilibrium blood level of the free Lanreotide. So you don't have the same degree of injection site reactions. You don't have as much pain from injection. It's much more convenient in people that are obese, and you may end up giving occasional injections into the fat where it doesn't have even blood levels over time, and symptoms can get worse if you miss. And it also makes it a lot easier when people are cachectic or thin and don't have a big butt, and you try injecting octreotide LAR with a long, wide needle. It's very difficult to do that over and over and over. It's very uncomfortable for people, and this is another alternative. They're both good, but this is Lanreotide. So randomized trial, this is from the New England Journal paper we published on Lanreotide versus placebo at the time of publication. Progression-free survival not reached with Lanreotide, progression-free survival 18 months in placebo. As I said, this is a longer progression-free survival than the treated group with octreotide LAR. So it's confusing. Subsequent follow-up was presented at ASCO last year. This is data that we presented on long-term follow-up of this study. And it turned out that in intestinal carcinoids, the median progression-free survival was 61.5 months. So Lanreotide can keep cancer from progressing for over 5 years, which is a remarkable period of cancer control for something that for most people has remarkably few side effects. And the control group, as I said, was 18 months, so it's really major. If you took the whole study of all sites together, which is the primary study design was to have pancreatic and gastrointestinal neuroendocrine tumors, the overall progression-free survival for everybody was 38.5 months. That's because the progression-free survival with the pancreatic primaries was a tad short. So 38.5 months was the number for the whole study. There was also a study of Lanreotide for carcinoid syndrome that goes by the nickname of which goes by the nickname of ELECT. Now, this ELECT trial was tricky to do because we already had octreotide on the market, and this is for treating carcinoid syndrome, and you can't ethically withhold an active drug from somebody who's having major symptomatic benefit. So in order to do an ethical study, it was done like this. Everybody was given a bunch of subcutaneous octreotide to self-inject and taught how to self-inject. And they were told to self-inject so they wouldn't have too many bowel movements or flushing and control their symptoms. Then people were randomized between Lanreotide once every 4 weeks or placebo once every 4 weeks. Okay, and the reduction in the need for rescue was the primary endpoint. So this met the planned endpoint, and on that basis was approved. So now we have both octreotide and Lanreotide approved for treating carcinoid syndrome. Lanreotide is approved for treating carcinoid tumor. Okay, and other neuroendocrine. There's a study we did with Pasireotide, the one that inhibits multiple sites, not just somatostatin receptor type 2, but other somatostatin receptors. And it turns out that it's very exciting, as far as I'm concerned, that the group that got Pasireotide had over 5 months longer control of their disease than octreotide when you compare the two. However, Novartis decided to not further develop this in neuroendocrine tumors, and it just sort of sits there, although the drug is approved now for some pituitary tumors, but it's very interesting. I've also seen some patients with gastrinoma have unbelievable responses to this drug when other things didn't work, with gastrin levels going from like 6,000 to 600 in a period of a couple of months, and resolution of all symptoms of ZE. So I think it does have a place, but it hasn't been worked out completely. Pasireotide has a higher risk of getting diabetes, and some people even need insulin. It's a little bit more tricky to use than octreotide. Okay, the next thing we want to talk about is using the somatostatin analog as a ligand to deliver a payload for imaging or therapy. The green target that you see is the somatostatin receptor on the neuroendocrine tumor. The ligand in this case is something like octreotide or octreotate, and then it is linked through a chelator. It goes by the nickname of DOTA, is the one most commonly used. And then in the chelator, we can either put a reporting unit to make a scan, most commonly gallium-68, although other substances are being studied. And then you can also insert a cytotoxic unit, which most commonly now lutetium-177, but particularly in Europe, people have used yttrium-90. Yttrium-90 has the disadvantage that it has a beta that travels 12 millimeters, and lutetium has a beta that travels 2 millimeters. So there's more collateral damage from yttrium-90 in the liver. There's more collateral damage in the bone marrow since macrophages have somatostatin receptors, and you can get a higher risk of myelodysplasia and acute myelogenous leukemia, and a higher risk of renal failure. So we don't use yttrium-90 as much, but it's certainly active. Most of the studies now are being done with lutetium-177. And of course, new ligands, new radioisotopes are all being investigated, and people are doing lots of interesting things with this field. It's wide open. Okay, so to finally prove the effectiveness of this after it was being used in a non-randomized phase 2 trial in Europe for a decade, and over 2,000 patients were treated in a phase 2 fashion. It's remarkable. I don't think the FDA would allow that to happen in America. But people were literally coming from America and paying $60,000 in cash to be a participant in the study in Europe of getting lutetium-177 dotatate. But finally, a study was done, a randomized prospective study done in the United States and Europe, randomizing people between exactly the same scheme that was done in Europe, 200 millicuries of lutetium-177 dotatate. The Europeans call it 7.4 gigabecquerels, so if you get anything from Europe, you just realize it's the same dose. And that was given with triatide LAR maintenance to continue after the procedure. And the control group was something the FDA thought up, which is to give everybody 60 milligrams of octreotide. If 30 milligrams doesn't work, which is the whole population going to the study, they all had progression on 30 milligrams, double the dose of cold octreotide and see which is better. It's interesting that at the time the FDA insisted on that control group, there wasn't a single study showing either efficacy or safety of doubling the dose. And the maximum approved dose is 30 milligrams. So there you go. And it turned out to really substantiate the non-randomized data that have been coming out from Europe. There's an objective response rate of 19%. So most people who get this do not have a major shrinkage of cancer, even though in the popular mind, and patients on their blogs often think about it as nuking the cancer and getting rid of it, because it sounds like a cruise missile with a nuclear warhead on it that's just going right to the cancer and nuking it. So there are mechanisms of radiation damage repair and other things that just somehow allow cells to survive. There's a fraction of cells that probably have a lower concentration of somatostatin receptors. And the bottom line is not everybody has a major shrink, but 19% have response by RECIST 1.1 criteria. Another large group, majority of the patients have stability, and only a very small group will progress. Okay, so it's a terrific treatment when you see how long the progression lasts. This is from the New England Journal paper we published on NETR1, and you can see the progression-free survival not reached. And the control group progression-free survival was 8.4 months. So the take-home message from this is that doubling the dose of octreotide from 30 milligrams to 60 milligrams is pretty much a waste of time. And I think really the only real reason for doing such a maneuver is if somebody's having symptoms of carcinoid syndrome and you're trying to get it under better control, use whatever you need. But for treating cancer as an anti-cancer drug, by 8.4 months, half of the patients had had RECIST criteria for progression, meaning that the sum of the tumors was more than 30% larger by 8 months. So it really has very little value in tumor control. Yes.
Times where, although progression-free survival is the ideal cancer outcome that we're using, it seems to me that sometimes we're also just going for stability.
Stability for a short time.
Yeah.
But at the time, a lot of these patients were taken off study very soon. They went off after 3 to 6 months. So it was stable at the time they went off study. Well, no, the people that were stable did not go off study. It's a little bit, yeah, it's hard to see how they defined stability there, because you can see that most of the patients did have major progression. Okay, overall survival looks like it's a lot better with lutetium, but it's hard to guarantee the results when the majority of patients haven't had events. The majority of the patients in both groups are still alive, but it sure looks suspicious when you have a difference in deaths of 13 versus 22. Okay, we published this last year in Journal of Clinical Oncology. PRRT improves quality of life. You have improvement in diarrhea, in flushing, in pain, energy level, Karnofsky performance status, and health state score. So as a symptomatic treatment, it's really remarkable. It not only shrinks cancer or stops cancer from growing, but it actually makes people feel much better. And it has major value and quality of life. However, in the beginning of the treatment, when you're having the first of the 4 treatments, sometimes symptoms can be exacerbated by swelling induced by the inflammation of radiation. And you can have a temporary worsening of pain, worsening of bowel obstruction, worsening of a lot of different symptoms associated with tumor mass because of swelling. So who should be treated is an area of brisk discussion and controversy even, and something we talk about all the time at our tumor board. These are the things that I think are most reasonable. These are sort of modified criteria from the expanded access clinical trial where it was felt to be safe. Presence of metastatic neuroendocrine tumor. If somebody has an early curable tumor, you cut it out with surgery, you do funny things to it like this. Well-differentiated histology. Initially, it was only well-differentiated grade 1 and grade 2. I think it's reasonable in a select group of people, even with well-differentiated grade 3. Target lesions need to overexpress somatostatin receptors on gallium-68 dotatate PET or a trioscan. Nowadays, the former is the way to go. Creatinine needs to be less than 1.7 and creatinine clearance less than 50, or there's a big risk of renal failure. Good performance status and physiologic function, and their criteria for all different laboratory criteria, and really evaluation by a multidisciplinary team to determine the optimal timing, because it's not something that can be done over and over. A total of 4 treatments, 800 millicuries of lutetium-177 isn't something that can be repeated. Sometimes later on in your life, you can get another couple of cycles, but you'll never be able to probably to get 4 again because of hematologic tolerance and kidney problems. So you have to say, what is the best time to do it? Is it now or is it later? And are there other things that should be done first, like embolization, cytoreductive surgery, for example? So just a few other thoughts about this. 4 injections of lutetium-177 dotatate, 200 millicuries given every 8. If necessary, the interval between dosing can be increased up to 16 weeks. Dose can be reduced by 50%. You can adjust things if you need for toxicity. Patients have to be here for a good part of the day. There are lots of radiation safety precautions. And reduction in tumor size happens over many months. You can get a picture, an X-ray, say 6 months later, even 12 months later, and see continued shrinkage of cancer. And early on, you can even see swelling of tumors as a result of so-called pseudoprogression from inflammation. The more strongly positive the gallium-68 dotatate PET, the more likely you are to have a major response and to see tumor shrinkage. And the factors which predict a drop in platelet count, which can be significant and sometimes even need transfusions, are age greater than 70, bone metastases, or poor kidney function. For those of you who haven't seen gallium-68 dotatate PET, it's revolutionary compared to what you get on an trioscan. This is a picture that was published by Richard Baum. You can see there are 2 tumors in the liver in the upper left. You can see on the CAT scan you only see 1. On the fused image in the left lower, you'll see both of those things on there. The patient was treated with 1 cycle of PRRT with lutetium-177 dotatate. CAT scan looks like they're all gone, but actually they're still there. 1 more cycle, you can see on both studies they're gone. Unfortunately, this patient didn't go on to receive 4 cycles, but stopped after 2 and had a relapse at a year. Relapse was picked up much faster on the gallium scan than on the CAT scan. It's a really good imaging to complement what we do. Don't anybody think that it's a means of following cancer in response to treatment, though, because you can't measure tumor size on nuclear medicine imaging. You can have increased intensity either because the tumor is larger or because you did the scan a little bit sooner after the injection, or depending on the things that influence the somatostatin receptor concentration. You have to get a cross-sectional imaging like a contrast CAT or a contrast MRI to see if the tumors are bigger or small. The impact of gallium-68 dotatate scans on therapy and patients' management is remarkable. It's a study we did when I was in California in conjunction with a group at UCLA. We imaged 100 patients who had already had all the normal conventional imagings, including CT, MRI, scan, 60% of patients had a change in therapy, which is really pretty remarkable. And it was because of the fact that therapies change so often that the FDA actually approved this drug, not just because you might see 4 lesions instead of 3 lesions. That's not really enough to get it approved, but it really does make a difference in management. People that were going to have a liver transplant turned out to have 4 unappreciated bone metastases. People that were going to have surgery to remove something turned out that they had so many metastases that surgery was a waste of time. It just changed management in so many cases. Okay, next molecular target I'm going to talk about very briefly is something I've been working on for years and very interested in, which is the mTOR inhibition. It's turned out to be a major molecular target. This is a picture of some heads that are standing on Rapa Nui Island, a big island in Easter Islands. They've been there for hundreds and hundreds of years, probably weigh 100 tons and they're 100 feet high, and nobody knows how they got there. It's one of the wonders of the world, sitting there in this grass made of one enormous stone, and how the ancient engineers got them erected and what they're doing, nobody knows. But anyway, these statues of warriors are there. Somebody, who was sort of an enterprising individual, went to the Easter Islands to see these heads. And while he was there, he thought he'd strike it rich if he put some dirt in a Ziploc bag or whatever kind of a bag he had and take it back to America to analyze. Because he got this idea that with such an isolated ecosystem, it's probably 1,000 miles from civilization, maybe there's a species of fungus in the soil that had never been identified before, and maybe it makes an antibiotic like streptomycin, and maybe he'd find something really exciting. I mean, who would ever think that it would actually work? So he took his dirt back to America of all crackpot ideas, right? And he found a fungus that had never been found before. And he found an antibiotic that it made that had never been found before. So he named the antibiotic rapamycin after Rapa Nui Island. He had no idea what it did. And it works on an enzyme that had never been previously discovered. So we call the enzyme mTOR. That means mammalian target of rapamycin. Because you don't have any idea what you're doing, you make it sound all scientific. You have an mTOR inhibitor that's inhibiting mTOR. So there you have it. Well, in those days, the NCI had a big budget, and they were able to do a high throughput screening of chemicals to see what had anti-cancer properties. And people were just doing every chemical in the world. You know, they had like 10,000 chemicals all lined up, and they put them through in vitro screening to see what they did on cells in the lab and what has anti-cancer effects. For no rational reason. It turned out this had tremendous anti-cancer effects, which stimulated all kinds of research. It turns out that mTOR is a central regulatory enzyme, controls how much oxygen is being used, how much glucose is being used, how long the cells live before they have apoptosis. It's really a major regulator, and people started discovering that there's mTOR1 and there's mTOR2 and there's a whole pathway, and it's part of the kinase AKT mTOR pathway. And there you go. Well, it turns out rapamycin is the name of sirolimus. That's the generic name of rapamycin, sirolimus. Sirolimus is also used as an immunosuppressive when you use it with steroids. But if you don't use it with steroids, it's not very immunosuppressive. And it turns out that it's a wonderful anti-cancer drug. It also turned out that there are a lot of peculiarities that made pancreatic neuroendocrine tumor look like it was a perfect thing to be treated with this. There are defects in the tuberous sclerosis gene, TSC2. Protein product inhibits mTOR activation, and these people get spontaneous pancreatic nets. The neurofibromatosis gene, NF1 gene loss, which regulates mTOR activity, results in PNETs in people with neurofibromatosis. Sporadic PNETs co-express IGF-1 and IGF-1 receptor, which activates the PI3 kinase mTOR pathway, leads to increased cell proliferation. And gene expression profiling studies show downregulation of TSC2 and PTEN genes, which are negative regulators of the pathway. All this sort of came together and said, boy, doesn't this look like it would be great for pancreatic neuroendocrine tumor? So based on this, the largest study in the history of pancreatic neuroendocrine tumors was done with 410 patients. This is now a disease that has an incidence of 3 per million. And to get randomized on a study meeting eligibility criteria, that 410 patients from all over the world is a huge project. Everolimus 10 milligrams a day versus placebo. At that time, of course, nothing was approved, so placebo was a very reasonable control. And there was also a planned crossover, so if anybody ever progressed on placebo, they got active drug. Okay? Very strong separation of the curves, as you can see, with a p-value that was something like 10 to the negative 12. It's an unbelievable p-value. And the 11.4 months versus 5.4 months. Clearly not as long, these are median progression-free survivals, not as long as you see with PRRT and even with Lanreotide in untreated people, but certainly a major advance. And it was, and you can see that most people have some degree of shrinkage. This is a waterfall plot where every patient is a vertical line. Everything in blue is below 0 as tumors have gotten smaller. And you can see that even though it doesn't usually meet form criteria of partial response, most people respond. Placebo people were allowed to have octreotide, which is why I think some of those people responded. And then a similar study was done in carcinoid tumors of the intestinal tract and lung, and the curves are almost identical. So it's 11-month progression-free survival. So it was FDA approved for all of this stuff. There's a way of overcoming resistance potentially with inhibiting mTORC2 as well as mTORC1, which is the enzyme inhibited by everolimus. I did a big trial with that situation called CC223 with 40 patients with a very long progression-free survival. There's now a study that we're doing here at Mount Sinai using a dual kinase mTOR inhibitor, mTORC1 and mTORC2 inhibitor for people whose cancer progresses on CC223 progresses on everolimus. Do we have 2 more minutes, or do I have to stop?
Probably should break, because Stella's have to go to clinic.
Okay, well, I don't want patients to suffer, but anyway, I was going to talk about a few other molecular targets. Let me just fast forward for 1 second to talk about something of interest to gastroenterologists. I don't know if all of you are familiar with telotrestat, but telotrestat is an inhibitor of tryptophan hydroxylase, which is the rate-limiting enzyme that converts tryptophan into serotonin. You go tryptophan, 5-hydroxytryptophan, and 5-hydroxytryptamine, which is serotonin. And when you inhibit that enzyme, you stop serotonin production in a major way. And it has the extraordinary property that it does not pass the blood-brain barrier, so you don't get all depressed and jump off bridges while your diarrhea is getting better. But it has a major effect on diarrhea. You drop the serotonin level by 50% above what you could do with octreotide, and it cuts way down on diarrhea. So just realize that we have that drug in addition to other things. There's interest in gut microbiome and effects of various nutritional things. And this is a summary of all the things we have available and the way of systemic treatment. And we have to prioritize what we do when. And these are some of the features that go into making that decision. Is the tumor localized or metastatic? Is it liver dominant, in which case you can do ablations and embolizations, surgeries and look things, or is it widely metastatic? How is the pathology? Is it a really nasty one you have to treat with chemotherapy first, otherwise you can treat with other types of things first? Is the pace of growth stable or progressive? Don't just go by the pathology. You have to use your head and look at the films and see what's happening, because when you do, for example, an EUS and get a pancreatic biopsy with a fine needle, and it might say well-differentiated neuroendocrine tumor, but the cancer's doubled in the next 2 or 3 months. That's not a well-differentiated tumor. That's a nasty tumor, and you probably have a sampling error, and the pathologist can't accurately determine proliferation rate by a couple of cells in a needle. You need a biopsy. You need to do something, but you don't just sit and watch and say, don't worry, you have a slow cancer, because it isn't a slow cancer. Hormonal symptoms are very important. This kind of patients need aggressive treatment sooner, and patients have low symptoms. So you have to just think about the treatment options and risk versus benefit. So I think I better stop here and let everybody go to clinic. But thank you for letting me speak.